Thank you very much. So we're gonna show our initial experience with the Evoque valve. And as Dr. Spargias reminded us all, this is a TAVI round session, so anyone is allowed to pitch in while we talk and while we present the cases. So I guess we're just gonna show the first case now. It's an 89-year-old male, BMI of 25. He has been complaining of shortness of breath and fatigue for the past few months, and he's been in uptitrating his medication. These are the BNP levels. A TT and a T of shows an EF of 65% with torrential TR. Previous medical history, he had a mitral edge-to-edge repair almost 5 years ago, and he had a TAVI last year for aortic valve stenosis. And other pertinent history would be atrial fibrillation. So this is a patient with a Euroscore of 4 and a tri-score of 14%. So let's go to the images, and imaging people as well, we can have their comments. This parasternal lung axis, where we can see the ejection fraction, we can see the mitral device, and this is the short axis where we can appreciate torrential TR. More or less good tricuspid valve function. Yes, Dr.
If you go back a couple of slides, we can see also there's a transcatheter aortic valve replacement and also a Pascal P10 in the mitral. These two procedures have preceded by probably a couple of years ago. We did the mitral first, and then he had a paradoxical low flow, low gradient aortic stenosis. We fixed that as well. He did well for about 6 months, and then he started having symptoms again. He had this torrential tricuspid regurgitation. Quality of life was, and this very active 89-year-old, he was limited by early fatigue and some dyspnea. So we proceeded with further evaluation for possible intervention. Reasonably good right ventricular systolic function, a dilated though right ventricle. And here we see biplane imaging of the tricuspid, torrential TR. These are images from a transesophageal echo. We see well-functioning aortic valve, well-seated Pascal device in the mitral with mild regurgitation. This is transgastric views of the tricuspid. We see a tri-leaflet tricuspid valve with generous regurgitation from the center and center anterior area. However, it's a white jet overall. We considered it for maybe a Pascal device tier, but we considered that it would be multiple devices and a suboptimal result in this patient. This is inflow, outflow images from for the tricuspid. Again, severe. The ERO was estimated at least 71 millimeters square. And moving on to the CT scan.
So when we're considering these patients, obviously we don't always come across just thinking about Evoque, but we have the opportunity to send images to the company, and so we get a very comprehensive and apprehensive PowerPoint. And so, as Dr. Chrissoheris said, so we didn't have many choices for this patient, so Evoque, we're very happy to be able to offer this patient if he was accepted by the company. So these are measurements that we do at the tricuspid valve annulus, and you see the PDT where we measure both diastolar or systolar, maybe and systole, but we also see where the annulus is the largest in size. And we always need to keep in mind that we need to have some percentage of oversizing. This will come across later in the future, so the valve won't be dislodged, and we should anticipate an oversizing of 5 to 10%. And these are very beautiful images. So besides the tricuspid valve annulus, we measured the right atrium, the right ventricle. The distance from the IVC to the right atrium is very important, so it will assist for the delivery to come across. You get to see the images on the top right corner of the device. And you can also see the valve and the delivery outside of the training pavilion as well. And this is a CT angular measurement guidance. Currently there are 3 sizes available for the Evoque valve. On the left side, annulus is too small. On the way to the right side, annulus is too large. So basically there's no possibility for Evoque cases right there. And they also present to the PowerPoint how you're going to have your II, so you can anticipate, depending on your angle, how the delivery sheath will be within the heart. And these are moving images where we anticipate in 3D and 4D the right atrium, the right ventricle, any possible, as you can see the TAVI before, and you can see the clips, so everything comes into play, and you can have a very good idea as what to anticipate the day of the procedure. So let me just stop for now. We can have a very brief discussion with the panel and the audience. How would anyone go ahead, or what other choices someone else would do? Anyone? No?
Yes, Dr. Chrissohris.
Yes, thank you. I couldn't agree more. I wouldn't say that this is a good candidate for a TEER. I think you will end up with more than 2 clips, maybe. So, and then again, I think that we would have a suboptimal result. I don't know how about the trick valve system. I don't know what's going on with the hepatic veins and what's the interaction with the inferior vena cava there, and if there is space to implant the IVC valve. I would think of implanting a new valve there. That would be a good option. Of course, I know that's an Evoque case.
Compared to the trick valve, I mean putting 2 valves to the caval system, putting a valve into the normal area works much more physiologic. The results are coming, but especially in this case, septal leaflet is not also so much suitable. My question, for example, before tricuspid valve implantations, do you measure pulmonary artery pressure?
We always do, and with the TT, and we do invasive measurements, and at the time of screening and at the time of procedure. And it's a very good question, because especially for all these new valves that we don't have enough data, and for instance for the Evoque valve, we need to be very specific about the weight of the patient and how strict we are, because if something changes from the screening to the day of the procedure, we might need to change the size, or it might not be feasible. So this is a very good question, and in invasive hemodynamics, and we will hear about the invasive hemodynamics in the next session, it's one of the most important aspects, especially when you're treating the tricuspid valve.
May I stress something here? And I think that what Professor Kiel said is very, very significant and very important. It's what is the contract area reserve of the right ventricle? Because you end up sealing a torrential TR, and you have a right ventricle that's not functioning at all. So, or you have all this pulmonary pressure being transferred back to the RV, and then you have you're stuck. You don't know what you don't have any other options. So I think it's very important that you have a mean to kind of evaluate what's the contractile reserve of the right ventricle, and it will help you to see how the patient will go, progress after the valve implantation. Having said that, I think that it's very important also to stress here that we should not neglect the right side. We had a very good result with your TAVI and your Pascal clip in the mitral valve, and then the patient came back again. This means that the right heart is something that we shouldn't be ignoring, as we have been all these last years, because this is something that can hamper your good results from the all your efforts that you did in treating the AS and the MR previously.
So these are great points, and this is exactly what you said. So you're abolishing the TR. So this is new ground for us. We don't know the long term what would that mean, that you're abolishing the TR with the clip. You're minimizing. So yes, but now we're abolishing. So indeed, you're right. We don't know yet. This is something that we're waiting after these transcatheter procedures in the long term to show us, are we doing good or are we doing harm?
It's not a concept but I think, for example, myself, when we put TAVI for low output, low gradient aortic stenosis, we evaluate contractile reserve of left ventricle with dobutamine stress echocardiography, for example. I think for the tricuspid valve implantations and tricuspid interventions, a specific parameter is required to assess right ventricular contractile reserve maybe, and the hemodynamic parameters. There are some echocardiographic parameters like tricuspid annular TAPSE and the others, but there are some exact measurements are required, for my opinion.
Yeah, definitely we have to do a thorough evaluation of the right ventricle, do our full complement of right ventricular indices by echo, including STDI, strain of the free wall and the total strain of the right ventricle. TAPSE is a very basic tool, so we don't rely on it so much. And also three-dimensional ejection fraction of the right ventricle is something we always try to understand. In addition, we always do invasive hemodynamics to assess the severity of any pulmonary hypertension and pulmonary vascular resistances to understand what this ventricle is up against once the regurgitant flow gets treated. And it's all afterload, it gets a significant afterload. So we have a full understanding of the right side before we begin these procedures.
I'm no imaging person here, but I would like to pitch in here an idea. I don't know, there must be data on that. I don't know what's the place of MRI or stress MRI in these people. And you could have a better assessment of the right ventricle using an MRI, and maybe that's that's one of the many ways that you could pre-assess what's your contractile reserve on that right ventricle.
We use also a clinical marker for us is whether we can balance a patient or compensate a patient with diuretics and bring him to a steady state point. If you have a patient who is coming in with ascites all the time, it's very difficult with massive doses of diuretics, then most likely we lost our opportunity. But in this particular patient, it is a patient who was fairly active, did not require heavy doses of diuretics, and he had some indices of good right ventricular function. So we have to take that into account as well.
In addition, these patients are usually very sick.
Correct.
Okay, let's proceed now. We're going to need to take all the time of the break as it goes. Vlasis is waiting for his own presentation. So let's go ahead with the rest of the case.
I think we... Okay, so very briefly, this is how the Evoque valve is. Unique design, 2 stents, 9 anchors that go under the hinge point of the tricuspid annulus, 28 French sheath outer diameter, and right now we have 3 sizes of the valve, and you get to see this is the delivery sheath. You have the white knob, the blue knob, which is about the ventricular and the atrial release of the valve. And so, and Dr. Spargias can tell us more about the procedure. So you can see we have the extra stiff wire in the right ventricle. And
so here we rely heavily on three-dimensional echocardiography, and in particular multiplanar reconstructions to create what we call the home view. So we do a 3D of the tricuspid valve, and then we analyze that to get on the left upper image is our commissural view, where we orient ourselves posterior and anterior. On the right upper is the septal and lateral orientation, and on the left lower quadrant is the short axis of the tricuspid valve in a view that is somewhat similar also to the transgastric view with the aortic valve at 5 o'clock. So this view is a view that we rely heavily during this implantation. There's multiple steps for the release of this valve. You see here that we're at 90 degrees of anchor exposure, in which case we, on echo, we want to ensure that all the anchors are sitting below the leaflets and that the leaflets are as above. So we have to rotate and see everything. Here we have atrial expansion of the valve. Again, we rotate through all the anchors as possible to make sure that all the anchors are nicely securing the leaflets, and that they're coming up to the hinge point of the leaflets. Subsequently, the atrial expansion will take place. Again, it's a very staged process, a very deliberate process. And here we have to take away the cone from the valve. Essentially, we're fully expanded now, and the valve is released.
And that's how the
And the
future looks like.
system looks user-friendly, I think.
Yeah, so initially when you have, just try to be very quick, when you have your extra stiff wire, you just make sure that the wire, and based on the echo, it's not somewhere lodged under the papillary muscles, because this will make major difference in the procedure. So it's very running freely. And then you just have, you just push in the delivery sheath. But as Dr. Chrissoheris said, it's based on a TE, so you got to be very patient. We showed it very quickly, but it takes very long time, step by step, to make sure that all the anchors are exactly where they have to be under the leaflets. And of course,
yeah, this is now 3D from the right atrium, visualizing the prosthesis. And this is by color. We don't see any PVL. Nice laminar flow in biplane imaging. Full restoration of the tricuspid valve function, and with no significant gradient.
Congratulations for the excellent case.
If I may just make my comment, as an interventionalist, this procedure is the simplest procedure probably you've ever met in your practice, because the only thing you have to do is to advance the capsule of the valve to the correct position, and then everything is done very slowly. You just release gradually and in steps, and you rely heavily on the echo imaging to make sure that the positioning of the valve is very correct to almost to 1 millimeter or 2 millimeter. So this is what takes time. As for interventional skills, I would say minimum is required. But as in every procedure, the beginning is the most important part. So in this procedure, the beginning, I mean the correct coaxial positioning of the capsule into the tricuspid annulus plane, it's defining the success of the procedure. Everything is very slow and very simple after that. So that's why the initial positioning of the wire, like Konstantinos said, is very important to make sure that it goes to the RV apex. And then everything, it'll be very easy. As soon as the patient is accepted, the anatomy is screened and is acceptable. And just one last comment, there is a new size, a larger size, the 56 millimeter valve that will be available next year. And I think with that, all the range, essentially, basically, of the tricuspid anatomy will be good for this valve.
Thank you, Kostas. Excellent result. Now, I want to return to Vlasis.